to welcome you to this afternoon's webinar entitled, What Healthcare Providers Need to Know About the Affordable Care Act, or ACA. I'd like to start with a few housekeeping rules. If you do experience any technical difficulties during today's webinar, please contact GoToMeeting.com corporate account customer support at the 2 numbers listed below. And at the end of the webinar, we will be fielding questions. So at that time, if you would like to either type in your questions in the chat or question box, we will take your questions. Also, feel free to type in any questions you may have throughout the webinar. Also, we may be able to take questions verbally. So when we get to that point, if you raise your hand, there is a raise hand button. I can also take questions that way. With that, if you can hear me and if the audio is okay, could you please raise your hand? Okay, great. Thank you. Today's webinar is co-sponsored by the Hopkins Center for Health Disparity Solutions, the Culture Quality Collaborative, as well as the Marblestone Consulting Group. A little bit about our center. The center was founded in 2002 by Dr. Thomas Levis, and we are considered a center of excellence, a national center of excellence in health disparities research by the National Institutes of Health, National Institute on Minority Health and Health Disparities. Several of the programs that are within our center have to do with organizational assessments and organizational cultural competency. For more information about these tools, please feel free to visit our website at www.clearview360.org. We have organizational cultural competency assessment tools available for hospitals, patient-centered medical homes, as well as behavioral health and social services settings. In addition, we have a collaborative of healthcare organizations called the Culture Quality Collaborative, and we are working together to provide evidence-based solutions to organizational cultural competency. And with that, I will turn the presentation over to my colleagues, Andrea and Michael Thompson.
Thank you very much, everyone. Appreciate you joining us this afternoon. My name is Michael, and I will be leading the first half of this afternoon session, and Andrea will take over a bit later. Next slide. So our discussion points for this afternoon are as follows. We're going to provide a brief definition of the Affordable Care Act. We're going to describe for you some of the main changes that have happened to date. Talk a bit about how the Affordable Care Act may affect you and your family. And then Andrea's going to spend some time specifically talking about how the Affordable Care Act may affect your work as a healthcare provider. And then at the end, we'll take your questions. Next slide. Next slide. Okay, so the Affordable Care Act, also known as Obamacare, was signed into law in March of 2010. It was later approved in 2012 by the Supreme Court, and it was designed to be phased in over a 10-year period. Next slide. So the purpose of the Affordable Care Act really involves 3 items. The first is to make health insurance available to more people, to ensure that health insurance was more affordable, and then lastly, to make it easier to understand, to clarify it. Next slide. So the key activities today that I want to cover with you date back to the beginning and move through 2013. Specifically, we'll be talking about the individual mandate. We'll talk about the young adult coverage, pre-existing conditions, lifetime limits, as well as annual limits, a bit about the Medicaid expansion, and then we'll spend the bulk of our time talking about the healthcare insurance marketplace. Next slide. So one of the most talked about elements of the law is this individual mandate. So the mandate stated that everyone had to have insurance beginning in 2014. And there are certain forms of coverage that would be accepted for under the law. And we wanted to point those out for you immediately, specifically public insurance, so Medicare, Medicaid, any insurance that you would get from work, any employer-sponsored insurance, an individual policy, any one that you would purchase on your own, and of course any policies that you would get through the marketplace. If you choose not to get insurance in 2014 and you don't have one of these accepted forms of coverage, you could face a penalty, and we'll talk more specifically about what that could mean for you. Next slide. So what is this penalty? As you can see in the chart here, I've listed what would happen within the first 3 years. Beginning in 2014, for example, the penalty would be $95 or 1% of your household income, whichever is greater. And that increases, so for example, to 2016, where that amount moves to $695 or 2.5% of your household income. Now, the amount that would be charged for minors within the household would be 1/2 of each of those amounts. Next slide. There are certain exemptions. If you happen to fall into one of these categories, you're not required to have insurance and will not have to pay a penalty. So as you look at some of these, including whether there's a hardship as defined by Health and Human Services, for example, if the cost of a health plan is 8% of higher of your income, that would be considered a hardship, as well as making sure that you live outside of the U.S. or that you may not be able to afford coverage. And of course, that last item, if you're a member of an Indian tribe, you would also be exempt. Next slide. This item is probably the most popular of the changes of the law, and it allows, what it does is it allows parents to carry their children on their policy to age 26. Now, this is despite a variety of conditions which you see here. They could be married, they could live outside of the home, they could even be financially independent. In fact, they could even have coverage at work and still be able to be covered under their parents' plans. Next slide. Pre-existing conditions. This is another key change under the law. And the pre-existing conditions prior to the law was one of the probably the most talked about issues associated with health insurance and health plans. This goes away in 2014 for everyone. It actually is in effect for anyone under 19 today. So by 2014, there will be no pre-existing conditions that could be used against individuals who will be applying for health plans. Next slide. Yet another key change is the removal of lifetime limits. Before the law went into effect, insurance companies could really cap how much they would pay for an individual's expenses over the life of the policy. So if the lifetime limit for an individual's policy was $100,000, that's all the insurance would pay against that policy. So all of your costs after that period would be on you, and for many individuals, that could mean as much as bankruptcy. Keep in mind that lifetime limits only apply to essential health benefits, and we'll talk more specifically about those as we move through the presentation. But you can think of essential health benefits as those benefits that you would expect to see in a comprehensive health plan. Next slide. So what if you can't afford insurance? What are your options? Well, depending on your income, you actually may be able to get help in the form of discounts, which are referred to under the law as advanced premium tax credits, and that would be paid on your behalf to the insurance company for your premiums. Or the second item you see there, help with out-of-pocket costs, cost sharing, which would be against deductibles, co-pays, or co-insurance. Now, to receive either of these, your income would have to fall between 100% and 400% of the federal poverty level. And so, for example, as an individual at 100% of the federal poverty level, your income would be $11,490, and at 400%, it would be $45,960. Next slide. So let's talk about one of the key elements of the law, Medicaid expansion. So One way that the government thought to provide coverage for a larger number of consumers was to expand Medicaid. And by doing so, the planners believed it would close the coverage gap. Now, this gap existed for individuals who made too much to qualify for Medicaid, yet too little to buy private insurance. Now, the perceived benefits associated with the expansion of Medicaid was one, to close that coverage gap. So there would be an opportunity for those individuals to receive coverage, and also to modify or change the cost of coverage, Medicaid coverage, so that the government would pick up, the federal government would pick up 100% of those costs and continue to do so from years 2014 through 2017, and then pick up 90% of those costs afterwards. Next slide. As we continue with the discussion around Medicaid expansion, the current breakdown of states with and without Medicaid is really almost even. So right now, as we speak, there are 26 states that have expanded Medicaid and 25 that have not. Next slide. So for an illustration of the breakdown, we provided this map where you see the darker blue states. Those are the ones that have expanded, and the lighter blue states have not. Now keep in mind, states that didn't expand Medicaid can choose to do so in the future. Next slide. Some of you may be wondering what's happening to Medicare. Well, Medicare is protected, and those covered under Medicare don't need to make any changes. As a result of the law, the Medicare beneficiaries will receive preventive services at no cost. Those preventive services will be available to non-Medicare beneficiaries as well. I'm sorry, they will be available to individuals who choose coverage in the marketplace as well. Medicare beneficiaries will also save money on their brand name drugs, as much as 50%. And then the donut hole, which is that threshold that you reach at $2,970, which some of you may be familiar with, in covered drugs, that donut hole actually would be closed in the year 2020. Next slide. And then there's COBRA. What happens to COBRA in 2014? There's also a fair amount of questions about this, and COBRA, as you may know, is the government program that allows you to keep your insurance after you leave a job, but you're also responsible for the full cost of that. So under the law, you will have the option of avoiding COBRA and going directly to the marketplace to purchase insurance. And the marketplace will provide multiple plan options, which we'll be discussing in a short while. And it may offer lower costs as well to individuals who are seeking to remove themselves from COBRA and find a less expensive plan. So that takes us to a discussion around the marketplace. Now, this marketplace has sometimes been referred to as exchange, and this is where individuals and small businesses can go to buy private insurance. So when can you enroll in the marketplace? As far as the initial open enrollment period, it actually already started. It started on October 1st and will end in March 31st of 2014. Of course, there are a whole host of issues associated with the government website, as you probably have heard, and they're expected to be finished by the latter part of November. And after the initial open enrollment period, the open enrollment periods thereafter will begin on October 15th and end on December 7th, which will also coincide with the Medicare open enrollment period. There are special enrollment periods available that involve certain conditions, and we'll talk specifically about those in just a minute. Next slide. There are three types of marketplaces. And depending on where you live, you would be participating, or you could participate in one of these marketplaces. The first type is a federally facilitated marketplace, where the entire system is run by the federal government. Secondly, you have the partnership marketplace, which is run by the state. In the first example, if you're part of the federally facilitated marketplace, you would go to healthcare.gov purchase private insurance. And the partnership, which is run by the state with assistance from the federal government, that would be Delaware as an example, and you would choose, it's called Choose Health. And lastly, there's a state-run plan run entirely by the state. An example of that would be Maryland, and theirs is called the Maryland Health Connection. Next slide. So how does this marketplace work? The marketplace was really designed with intent of being simple and easy to use, and it works as follows. There's one process that would really be used to help determine eligibility as it relates to health plans and qualified health plans in particular within the marketplace. And those are those plans that have been certified and vetted by the insurance companies in the states and or governments that are running the marketplace. It takes into account the discounts associated with credits or reduced cost sharing, as well as any eligibility that you would have for Medicaid or CHIP as part of the process. And we'll show you the four-step process in just a few minutes of what that would look like. We'll also be offering a choice of plans and different levels of coverage. And because of the number of insurance companies who would be included in the marketplace, they would all be competing for business and presumably help to lower the costs. Next slide. So here's that four-step process. In step one, you would create an account. In step two, you would enter information about yourself and your family. And then from there, you will find out what you qualify for. So if you qualify for Medicaid, as an example, you will receive a confirmation, and then you'll be required to complete additional information within your state associated with that. However, if you qualify for the marketplace, you will then see a list of plans to choose from, and also see the different types of discounts that may be available to you as a result of the information that you've entered. And once you've gone through the process of entering that information, you'll get a confirmation that you have been officially enrolled and that your coverage will begin on January 1st. Next slide. With respect to eligibility and enrollment, the marketplace requires that you live in the service area that you're seeking. You also have to be a U.S. citizen, and if you're not, you have to be lawfully present in the U.S. for the entire period for which open enrollment is sought. And you cannot be in jail or in prison. So as we look at the special enrollment options, there are times when you are allowed to enroll outside of the standard period, or the standard open enrollment period, I should say. And these times are called life event changes. And we provided just a series or a few of those so that you would get an example of, or see an example, I should say, of what certified life event changes would be. Next slide. All health plans that will be available within the marketplace have to be qualified, and as I mentioned, they have to go through the proper certification and evaluation process. In addition, there are what are called essential health benefits, which you see within the listing here, and this is essentially what determines a comprehensive plan and what they're referring to as a qualified health plans. And if you notice that many of these items listed in this category are pretty straightforward. You would expect to see hospitalization, maternity, and newborn care. But one of the others down in the right corner, pediatric services, within the marketplace, those will actually include oral and vision care, which was not something that the majority of the plans had available or were available under the law previously. Next slide. So each marketplace will have four main health plan levels, and these are commonly referred to as metal tiers, beginning with bronze, moving up to silver, gold, and platinum. Now in the second category of the chart that you see before you, the bronze plan is the least expensive, and with that, the insurance plan, would pay 60% of the cost of that plan, and the insured or the individual would pay 40%. They refer to that as the actuarial value. Obviously, as you move up with the percentage that the plan plays, moving up to gold or actually platinum, which actually covers the greatest amount, provides the greatest amount of really to try to create a certain standardization about what individuals and small businesses would see as they look to compare the different plans. And also to serve as benchmarks for those premium credits that you heard me refer to, as well as those cost-sharing subsidies that you would get depending on your income and family size. Next slide. Now, in addition to the 4 main plans, there's a 5th plan, which is referred to as a catastrophic plan. So this plan is really available as an attempt to provide a lower cost option with less coverage. So with this plan, it's a very high deductible, and it's really, you can think of it as sort of a safety net coverage plan. With it, individuals will receive 3 primary care visits within a year. It will not provide other services, for example, like prescription drugs or shots, but it will provide a much lower monthly payments than the standard or traditional health insurance plans that you are familiar with. So in essence, you would end up paying several thousands of dollars out of pocket before the full coverage would kick in within this plan. Next slide. As far as eligibility, it's really designed for young adults who are under 30 years of age, as well as those who could obtain a hardship exemption from the marketplace. For example, those with limited incomes who didn't qualify for other services. And as part of the catastrophic plan, there would be no added discounts such as the tax credits or the premium assistance that you heard me mention earlier. There is financial help available outside the catastrophic plan that I mentioned among the 4 metal tiered plans, the bronze through platinum. Depending on your income and family size, you could receive advanced premium tax credits, which would help to lower your premiums, or assistance with cost sharing to help against deductibles and co-insurance. So with respect to the advanced premium tax credits, to help lower the cost, you could be eligible for those to help against your premium. You could take those credits against your premium right away, or you could do it later on at tax time. The assistance that you would receive, provided you do qualify, would be paid by the government directly to the insurance company. Now, as far as eligibility is concerned, you see that there's an added degree of detail there about household income family size, as well as not qualifying for government health plans, as well as whether or not that you have affordable health insurance at work. So those are the eligibility outlines or details associated with this. We talked a little bit about free preventive services earlier. Before the passing of the Affordable Care Act, most screenings actually would require a copay. But now, in an effort to better manage those costs and keep consumers healthier, the marketplace plans will offer standard screenings free of charge. And this is just a short list of what they include. You may notice that the second to the bottom, the list of the item in the second to the bottom of this list, domestic and interpersonal violence screening, that was not included among screenings prior to the Affordable Care Act. Next slide. Medicaid and CHIP are also options available within the marketplace depending on income and family size. So when you go to the marketplace and you do apply, one of the options, as you heard me allude to, would be a qualification for Medicaid and CHIP, particularly for those states that have expanded Medicaid. So individuals who enroll in the marketplace could be directed to their state programs as a result. Next slide. So this is a snapshot of the Medicaid eligibility requirements in states that have expanded Medicaid. You see that it focuses on individuals between 19 and 64. It gives you some guidelines around where the individuals will fall with respect to the federal poverty line, and it just kind of gives you some clarification about how things are calculated or how the numbers are calculated. So at this point, I'm going to turn it over to Andrea, where she'll be discussing the specifics associated with how your work may change as a healthcare professional?
Hi everyone, I'm Andrea, as Michael said, and I'm going to just talk a little bit about some of the elements in the law that are specific to healthcare professionals. I know you're interested in how your life is going to change, and one of the obvious changes, of course, will be there will be more people in the system with coverage, and many of these individuals have not had health insurance before. So they won't necessarily know how to use health insurance. They won't understand the language of health insurance, the terms that are currently used in health insurance. Those of us who have had health insurance for years, it's complex for us. So you can imagine those individuals who are coming into it for the first time trying to understand a lot of the terms like copay and coinsurance and out-of-pocket max. Those are the new terms those are terms that will be new to them. So as well as the complex terms and words that are used in healthcare. So what I'll say to you is prepare to educate. Those of you in private practice will have to help your individual patients and customers, and of course those of you in healthcare organizations will fall into some of the same areas. You have to prepare to educate because health literacy is an issue, even for those of us who are educated and who have worked in this system for a long time. Health literacy is an issue. Understanding the language of health, how to navigate the healthcare system, it's going to be very challenging. So anyway, I'll talk about some of the specific elements of the law that will affect healthcare professionals. Next slide. All right, I just made a list of things, and I'll go through these briefly but individually so I can point out things that have changed. And some of these things are already in effect. Some will be forthcoming. Michael talked about free preventive care. For those of you who are in patient care and working directly with patients, in the past you may have been collecting copays for things like mammograms or colonoscopies. Moving forward, that is preventive care is free, and they will not have to pay copay or co-insurance. The public health programs, we've had $15 billion put forth in a public health fund, and this is really aimed at prevention and bettering our public health programs, things like smoking cessation and combating obesity. Some of you may even have access to those grants or funds that are available federally and in your states. Cracking down on fraud. This has been happening for a while now. The efforts that the CMS has put forth in fighting fraud, in 2009 they returned more than $2.5 billion to the Medicare Trust Fund. So the new law is putting new resources in place to continue to help healthcare providers to screen and to reduce fraud and waste in Medicare, Medicaid, and in CHIP, which is the Children's Health Insurance Program. Rebuilding the primary care workforce. To strengthen the availability of primary care, there are new incentives in place now to expand the number of primary care doctors, nurses, and physician assistants. And these kinds of incentives are funds like scholarships and assistance in loan repayment as well, and there will be some tax relief for individuals in this system as well. We're going to have more people on Medicaid. Michael mentioned Medicaid Expansion. So there are some states who have already chosen to expand Medicaid. You can expect more individuals in those states using the system coming into your offices or places of or your healthcare organization. There are some states who have not made the decision yet, and of course there may be states who decide not to expand Medicaid at all. Increased payments for rural healthcare providers. Today, 68% of medically underserved communities across the nation are in rural areas. So, and in many of these areas, they have trouble attracting and retaining medical professionals. So the law is providing increased payment to rural healthcare providers to incent them to continue to serve their communities. Constructing more community health centers. The law provides additional funding and new funding to support the construction and expansion of community health centers. Right now, community health centers in our country serve more than 20 million patients, new patients across the country. This was effective in 2010, and it's continuing today. So, improving healthcare quality. The law establishes a new Center for Medicare and Medicaid Innovation program that's going to be testing new ways of delivering care to patients. These methods are expected to improve the quality of health care, and they're also hoping to continue to reduce the growth rate of health care cost in programs such as Medicaid and CHIP, which is the Children's Health Insurance Program. Transitional care for seniors leaving the hospital. You may have heard about the Community Care Transitions Program. It's to help high-risk Medicare beneficiaries who are hospitalized avoid unnecessary readmissions. And they want to do this by coordinating care and helping these individuals connect to patients within their community. So for those of you who are in hospitals, you likely have heard of the Community Care Transitions Program, which started in 2011. A lot of new innovations are being targeted toward waste and reduction of cost. So the government put out grant requests or requests for grants and proposals for individuals who are interested in working on new innovations, and that's been out now for a while, and a number of companies across the country as well as small businesses have put forth proposals on new ideas for decreasing waste, reducing cost, and of course improving quality as well. Linking payment to outcomes. The law establishes a hospital value-based purchasing program in traditional Medicare. This program will offer financial incentives to hospitals to improve the quality of care. Hospital performance is required to be publicly reported, beginning with measures relating to heart attacks and heart failure, pneumonia, surgical care, and healthcare associated infections, as well as patients' perception of care. So payments will be linked to your outcomes. They are encouraging integrated health systems. You certainly have heard of accountable care organizations. These groups allow doctors to coordinate patient care and improve the quality and help prevent disease and illness and reduce unnecessary hospital admissions. If accountable care organizations provide the quality of care that they are promising they will, if they help to reduce the cost in the healthcare system, they get to keep some of the money that they're helping to save. That was effective January of 2012. Reducing paperwork and administrative costs, we all hope it works in that area. The law will institute a series of changes to standardize billing and require healthcare plans to do things electronically. You've heard of electronic medical records. Well, a lot of the other paperwork and churn in the system, they are hoping to move that paperwork to electronic records. And that first regulation became effective October of 2012. Next slide. Let's continue. Fighting health disparity. To help understand and reduce health disparity, the law is requiring any ongoing or new federal health program to collect and report racial, ethnic, and language data. So a number of those regulations have taken place already. The first one was effective March of 2012. Bundling payments. The law establishes a national pilot program to encourage hospital doctors and other providers to work together to improve the coordination and quality of patient care. And they're asking for payment bundling. Hospitals, doctors, and providers are paid a flat rate for an episode of care rather than all of the fragmented types of billing that have occurred in the past. So they are encouraging bundling of payments. Increasing Medicaid payments for primary care. For primary care doctors who are treating Medicaid patients now, their reimbursement or payment will be no less than 100% of the Medicare payment. So Medicaid and Medicare payments are to be comparable. Coverage for individuals participating in clinical trials. Insurers cannot just drop coverage for those individuals who have chosen to participate in a clinical trial. It certainly applies to clinical trials that treat cancer or other life-threatening diseases. This becomes effective January of 2014. Paying physicians based on value, not on volume. A new provision in the law will tie physician payments to the quality of care that they provide. So physicians will see their payments modified based on the quality of care for their patients. So those who provide good quality care will receive higher payments, and those who do not will see their payments decrease. And of course, culturally and linguistically appropriate services. The law has a provision for healthcare organizations and healthcare providers that, we have to begin to communicate and deal with our customers in a more culturally and linguistically appropriate manner. Your healthcare organizations, your hospitals, your offices, you really need to look at, are you ready for various cultures within your community? Do you have the language services that are appropriate to service those individuals who are parts of your community as well? Next slide. Now, we all know that you've heard a whole heck of a lot about the amount of churn that is in this new act. So I wanted to give you just an example of something that could happen and what you need to be prepared for regarding something called split eligibility. And this is just an example of what could occur under the new Affordable Care Act. A family of 4 could actually have different coverages and be under different delivery systems. So let's take this example. A pregnant mother, her 5-year-old child, and her husband have a household income which is 150% of the federal poverty level. Now, the mother's pregnant, so right now she would qualify for Medicaid until 60 days postpartum. And then she'll transition to the Advanced Premium Tax Credit Program, which is the program through the Healthcare Exchange. The father qualifies for the Premium Tax Credit Program. The newborn will qualify for Medicaid until they're 1 year, they turn 1, and then they'll transition to CHIP, which is the Children's Health Insurance Program. And the 5-year-old in the family is currently on CHIP. Next slide. So if you are a private physician or maybe even a hospital, you can have a family on all different, in and on all different plans and in different delivery systems. So there's going to be a little bit of churn in the system or a lot of churn in the system early on. This family that I just described to you, if the father or the mom lost a job, it's likely that the scenario that you see here could even change. So within 60 to 90 days within a family, their coverage, their plan could change. So your billing people will be driven mad by some of this churn and some of the many changes that can occur within a family. So education here is going to be absolutely imperative for your office staff and for you. To be able to help your patients and your customers, you've got to understand the many different scenarios that might occur under the law. Next slide. So, given that, we've got some recommendations, you may want to start developing a cheat sheet. If you are a private physician who has a receptionist who might be dealing with patients coming in, you may want to start developing a cheat sheet for that individual now so that they understand some of these scenarios and can direct your patients accordingly. We're certainly suggesting that you train your staff on the Affordable Care Act basics, give them an overview of this act, discuss with them many of the things that we just covered with you, which are the basics of the law and some of the things that could happen. There will be churn, changes in insurance type based on certain living conditions or losing or gaining a job. There will be a great deal of that if you think about the transients that some people experience in the workforce today. You've got to be prepared to answer some of the questions that may come as a result of that. Next slide. So, some points to remember. The marketplace is the new way to find and buy health insurance. You're going to have qualified individuals with the ability to shop for health insurance that fits their budgets. Individuals and families may be eligible for lower cost on their monthly premiums and their out-of-pocket cost. Newly insured individuals will require special attention and different systems. Like I said, many of these individuals have never had insurance before, so they won't know necessarily how to use it. They certainly won't understand some of the language of health insurance. Next slide. Insurance will continue to be sold outside of the marketplace as well. It won't always be just in the marketplace. There's private insurance out there that people have bought for years, so insurance will continue to be sold outside of the marketplace. Purchase from the marketplace is not required. The marketplace, however, is the only place to get premium tax credit and cost sharing reduction. So if you purchase outside of the marketplace, you're on your own, basically, is what that means. Next slide. Okay, Michael, did you have any points that you wanted to make as I summarized?
I think we're good.
Okay. Well, we did have a couple of questions that were pre-submitted questions. I think Cherie received 3 of them, and we're going to go through those 3 questions first before we open it up to other questions. Cherie, can you read those questions?
Yes, I can. Thank you very much, Michael and Andrea. I appreciate that presentation. So yes, we did receive 3 questions prior to the webinar, and then we will address the questions that we received during the webinar. Actually, before I proceed with questions, Michael and Andrea, I wanted to state we did record today's webinar, and the slides will also be available after the webinar. We will be posting them to our center's website, and we always post our webinar recordings to our center's YouTube page. So that will be sent out within a day after the webinar. So I just wanted to bring that to your attention. So turning to the questions, the first question we received: many of my friends claim their insurance is going up. Isn't the point of the ACA to provide insurance and lower premiums?
This is Michael. That is certainly likely that your friend's insurance could be going up. In fact, insurance has been going up well before, year after year before the law took place. And you're right. The intent of the law was certainly to help bring down costs and make it available to more individuals. And part of what we mentioned before, as you may recall, the tax credits as well as the cost sharing are designed to help individuals within the marketplace bring their costs down.
For some of us, I know with me, I retired from pharmaceutical industry 3 years ago, and I still have health insurance through my employer. And since I've been a retiree, every year the cost of care is going up. So whomever it is who submitted that question, the answer is yes. Some of us are continuing to face increasing cost of our premium. So the answer to your question is yes.
Great, thank you. Another question was, what metrics other than HCAHPS, and if you're not familiar with HCAHPS, this is basically the hospital-based patient experience survey that all hospitals are required to submit to CMS. And so they're asking, what can hospitals use other than HCAHPS to measure disparities in care, especially when there is limited data?
Well, I don't know of a whole lot of measurements. Certainly I know that Dr. Leveist and his team have prepared assessments where you can use their tools to actually assess disparities within healthcare organizations. And I don't know, Cherie, if this audience has had an opportunity to be exposed to your COA 360 assessment tool, but I know that tool does exist. I'm not certain, Cherie, do you know of other measures or measurement tools that are out there?
Well, there are several measurement tools. I can speak briefly to our Clearview 360 tools. Basically, those tools, again, were developed first for the hospital setting. We started off with a unit-based assessment. So think of assessing your emergency department or your labor and delivery departments. And our clients thought the unit assessments were very helpful. But from a CEO's perspective, that person wants to know how is the organization doing as a whole. So we launched our hospital-based assessment earlier this year. And actually, one of our Cultural Quality Collaborative members, who I think several of them were participating in today's webinar, Yakima Valley Memorial Hospital, is currently conducting their COA 360 hospital assessment as we speak. And when we're looking at these assessments, Andrea, you had mentioned providing culturally and linguistically appropriate services. So our assessments measure the enhanced class standards that were issued in April of 2013. They also look at the Joint Commission standards on effective communication, cultural competency, and patient and family-centered care. We also include the Human Rights Campaign Healthcare Equality Index Core 4, as well as a modified HCAHPS, again, to look at the patient experience. One thing that's really helpful about the tool, though, is that oftentimes we have data. If you have data at all, it's oftentimes in the aggregate, and you don't have the ability to drill down on race, ethnicity, and language. Our tools not only look at those three areas, but we also include gender identity, sexual orientation, as well as religion, and we will be including disability in the near future. So that's one of the tools that's out there. I do know that from a language access perspective that the Robert Wood Johnson Foundation had a program that was originally called Hablamos Juntos, which focused on the provision of Spanish language services in hospitals, but they expanded that to be Speaking Together, and they developed 6 quality improvement measures regarding the provision of language access services. So if you look up Speaking Together, you can get access to those tools. There are also other cultural competency organizational assessment tools out there. The American Medical Association has one called the CCATS, the Cultural Climate Assessment Toolkits, and basically there are also a couple of measures too that have been put out by the National Quality Forum. So if you look up disparities and measurements, you should be able to find some of those.
Yeah. And whomever submitted that question, it's a good question because quality is one of the aspects that the law continues to mention. And they also talk about, there's actually a provision in there that talks about culturally and linguistically appropriate services. So I think quality and that aspect, of culturally and linguistically appropriate services, they go hand in hand, because unless you can communicate and you understand an individual, how can you deliver quality health care to that person? So it's going to be critical as we move forward as healthcare providers to assess the kind of care we're giving.
Right, and also too, Andre, in addition to that, again, since we're focusing very much so on quality, with the Affordable Care Act, we already have the reduction of payment for avoidable readmissions. If hospitals and healthcare providers aren't already looking at this, you might want to look at this stratified by race, ethnicity, and language to see if there are issues where by not providing a culturally competent, health literate inpatient hospitalization, is that a reason why you're having patients who are readmitted? And then another way to look at your quality data, I would highly recommend the Massachusetts General Disparity Solution Center. They have quite a few years ago, they developed their equity dashboard or equity report, which looks at what services and departments are their patients being seen in. Are they identifying their patients' language needs? So I'll give you an example of what I mean by that. Many of you may go to your language line or your interpretation or language access services, and they can tell you for this fiscal year, our top 10 language requests were Spanish, Mandarin, Korean, Vietnamese, et cetera, et cetera. So that's your language requests. But many hospitals cannot give you accurate data on your actual language needs of your patients, meaning if I walked into a hospital and said, at this moment, please provide me a list of all of your patients who have a language need, what would your data look like right now? What would happen is you might have patients with the last name Rodriguez who are identified as being English-speaking, or they're thought to be Spanish-speaking, yet simply because they have a Spanish surname, and so that data isn't very good. And so, again, that's another area where you could be looking at disparities in care. And then, of course, looking at, if you're from an inpatient hospital, looking at your ORIX measures that you have to report for hospital compare, and if you're in an outpatient setting, looking at your HEDIS measures, and then starting to stratify that data by race, ethnicity, and language as well. And then moving on to our next question, we had a question of, will private doctors likely accept marketplace insurance, or will it likely be safety net providers and federally qualified healthcare centers?
This is Michael. The answer to that question is yes, that you can expect that they will accept those plans because there will be, as I mentioned, fully qualified health plans that will be comprehensive in coverage, and yes, you can expect that they will be.
Okay, very good. And at this time, do we have any other questions? You can feel free to either raise your hand if you are participating by phone and entered an audio pen, or if you would like to type in a question, I can take that as well. Okay, I do see a raised hand. Beth Lynn Gerard, I'm going to unmute you. Beth Lynn, can you hear us? Okay, if you do have a question, you may want to go ahead and type it in the question box, please. Okay, just came through. Thank you. Okay, no worries. Thank you. Any other questions? Okay, well, I am not seeing any other questions at this time, and as I mentioned, the webinar was recorded. We will be sending out the webinar recording link within 24 hours of today's webinar. It will also be posted to the center's YouTube page, and the PowerPoint slides will be posted to our website in PDF format. Otherwise, if you have no other questions, I'd like to thank you for your time, and always feel free to reach me after this webinar. And I also wanted to leave the contact information for Andrea and Michael as well with Marblestone Consulting. Oh, wait, I see another question came through. Let me see if I can take that. Let's see. Oh, okay, great. We did get one. Thanks for getting that one in. Let's see. The question is from John Ukadike, and it says, let's see, for the states that are not increasing Medicaid coverage, does this mean that people in those states will have worse access to health care than those in expanded states? Great question. Thank you.
Well, this is Michael. The answer is no. I think that what will happen in those states that didn't expand Medicare, they will have coverage gaps. In other words, those individuals who make too much I'm sorry, Medicaid, I'm sorry, thank you. For those individuals who fall within that coverage gap, in other words, they make too much to qualify for Medicaid, but not enough to go into the marketplace. Those individuals will obviously see some potentially higher costs. But in terms of the marketplaces within any of the states, whether it's federal, partnership, or state, because all of those plans will be comprehensive, we shouldn't see any significant difference there.
Great, thank you. We also have a question from Dr. Ann Barnes, and her question is, are there any systems in place or being developed to assist individuals with transitions in coverage that were discussed in the presentation, such as CHIP to Medicaid, or will this be the responsibility of the individual? Great question. Thank you, Dr. Barnes.
There are no systems in place that we know of today. That's why we're calling this a little bit of churn. I mean, every individual is sort of accountable for learning the system. Now, the federal government did, you know, right now they have navigators, they have phone lines that can assist individuals with some of these questions, but you know, once this enrollment period is over and a number of these systems go down, I don't know if the federal government is going to provide like a service line to help individuals navigate the healthcare system if they are not familiar with it. I personally feel a lot of these questions are going to be coming to healthcare providers, especially primary care physicians who are seeing a lot of these patients. I think they're going to be coming in asking, you know, all sorts of questions and expecting your office to help them navigate. That's why Michael and I are recommending that you train your staff as much as you possibly can on the Affordable Care Act, the healthcare, the exchange information, as well as going over some of these possible scenarios that could happen. Because right now there are no systems that we know of that have been put in place to address some of those concerns.
Actually, too, I was just wondering if by a quick show of hands, how many of you have interacted with navigators or assisters in your home state? Meaning, these are those who have been charged with enrolling people either in the federal marketplace or the state-based exchanges. Anyone? Or if you had a patient come into your office today, would you know where to refer that patient? With a quick show of hands. Okay, so basically I think one of the points we wanted to leave you with again is that I would start by having anyone with questions, whether, again, it could be family members, neighbors, people in your faith communities, in your own communities, have them start off at healthcare.gov, and when they do go to healthcare.gov, if it is a state-based exchange, as Michael had mentioned at the beginning, they would go to, say, if you were here in Maryland, you would go to the Maryland Health Connection. If you were in the state of Delaware, you would be led to another website, but really, you would want to have this information available in your offices to provide to your patients, because we mentioned that coverage begins January 1st, but you cannot enroll 3 days before January 1st and then expect to have coverage. So here we are already almost into November. We realize there have been glitches nationally as well as on state basis with people enrolling, but we do want to provide as much information to our patients as possible because they might not be getting that information from anywhere else.
Right, and you will have patients who absolutely miss the enrollment period. A lot of them won't realize they have missed the enrollment period, and they're going to come into your office, you know, with questions about Affordable Care Act or the health insurance, and they will not be able to enroll until the next enrollment period. The current enrollment period is until March 31st, right, Michael?
That's correct.
Right. So after March 31st, unless they have a life event, they will not be able to enroll for 2014. They will have to wait until the enrollment period opens in 2015. So if that's a patient who doesn't have insurance, they will, and they've been a private pay patient, they will continue to have to do that until they get insurance the next year. But that also may be an individual who is going to face the penalty because they did not enroll. So there's a lot of confusion, as we all know, that's out there, and a lot of folks simply aren't following any of this information. They will come into your office with those questions.
Right. Okay, are there any other questions before we end for the afternoon? Great. Well, we thank you for your time. Thank you for participating in today's webinar. And please look out for the email that has both an evaluation of today's webinar as well as the link to the webinar recording and the slides. Oh, one more question just came in. Andrea and Michael, I hope you don't mind. I'm going to try to take this one too because I don't want to cut anyone off here. Okay, great. Let me just see here. Okay, no, it was just someone thanking us for the webinar, so thank you. I thank you as well. Have a great afternoon, and with this, we will end today's webinar. Thank you.